Well, good morning. Thank you for the nice introduction. It's good to be back at the Rockefeller Institute. My thanks to the New York State Health Foundation for supporting this event today. I have to admit that when Dr. Martin first asked me if I could participate in today's event, I was a little bit surprised because I would be the neo-Luddite in the room, the techno-peasant, and in fact I think my kids know how to download more apps on my phone than I do. And I often run into Dr. Shaw, who shows me the latest and greatest on his phone, and I have no idea what he's talking about. So I was very surprised initially. But then I realized the opportunity today to look at not just data and technology, but what it can do to transform public policy making and what it can do to transform healthcare. And then it made a lot more sense as to why I was here today. So what I'm going to cover today is more about what is big data and why it's important, what we are doing here in New York and how we compare nationally, and the potential for data in moving the public health system forward. I know that you will get a wonderful and inspirational speech from Dr. Shaw. Dr. Shaw, as many of you know, was recently given the Data Liberator Award. He, in his time at the Department of Health, has done a tremendous amount to transform the way we think about the potential for data and to liberate data, literally, to begin posting information on the website that can help us in the furtherance of our public health goals. So I think that he was the perfect choice for your keynote speaker today. So before I begin, I just want to get a sense of how many data geeks we have in the room and have, through a raising of the hands, see how many people know what big data is. Okay. All right, so we got a lot of people in the room who know this stuff already. Big data. There's obviously a technical definition. Large volumes of complex, diverse, and timely data that require advanced technologies, management, and analysis to use. In healthcare, we have a few examples up here that show you exactly what that means. The first one on the top talks about human-generated data, the electronic medical record. These can also be things that doctors use like emails, correspondence about a patient's condition. It can be physician's note. It can be what's written in a prescription. A lot of this data is being collected right now in New York State through what's known as the State Health Information Network New York, SHINY New York, great acronym. And that data and information that's taken from the doctors is then placed into the regional health information organizations, who are sort of a repository on a regional basis for that information. Right now, we're not probably getting as much data as we'd like from this source of human-generated data, doctors' notes, things like that, but we're beginning to get there. The second category is the big transaction data. These are things like claims for services so that you understand what services people received. We have a lot of this in New York. We probably have more than we know what to do with. And so there is tremendous potential to tap into that data. It can be found through eMedNy. We're beginning to analyze some of that data through a salient technology, as it's known, to really drill down and see where patients are using services and how it's being utilized. The third one, surprisingly, is web and social media. I would say one of the best examples of this, that's one of the newest examples of this, is the Health Information Exchange, the New York State of Health, which is New York's website for people to go in and find out about health insurance options and compare prices, compare doctors, and compare networks of doctors. The category down on the left, biometric data. These are things like fingerprinting, genetic information, retinal scans, blood pressure, pulse, information that we, on an individual basis, sometimes we would like to know what is our blood pressure. And in fact, you can, as Dr. Shaw showed me, you can download an app on your phone and actually determine what your blood pressure is. But this is also part of the equation. And then finally, there's machine-to-machine data. These are things like sensors. When you think about providing services in a rural area, it's the type of technology that allows you to do that remotely. So big data, it's a lot of different data. I think that we all know that we have plenty of data out there. So the next question is, why does all that data matter when it comes to healthcare? I think obviously the point of the first panel this morning is about public health and being able to leverage this data for understanding why we need to focus on public health, what we can do in terms of prevention. When you look at the role of this in our economy and the potential for innovation in this area, you think about what role healthcare plays in the overall economy, In 10 years' time, we went from having healthcare be 13% of the GDP to nearly 19% of GDP in 2010. So there is tremendous opportunity there for this to not only be a way to improve public health, but to help our economy. A second major way, obviously, is disease detection. I think Dr. Burkhead will cover this probably more in depth in his remarks, so I won't cover it in mine. System transformation is incredibly important. And when I say system transformation, I'm talking about systems of healthcare delivery. So providers, hospitals, they can use the data in planning, they can use it in goal setting, they can use it for continuous quality improvement. And when we look across the state at the health systems that are healthier, they're doing better, they're having better results for their patients, they are using data for system transformation. It can also be used for efficiency, certainly timeliness in transmission of data. I would say a lot of health executives who have invested in health information technology are wondering when they're going to see the return on investment, and some of them are finally beginning to see that. They know that they've spent millions of dollars investing in IT systems. Now they're beginning to see the payoff through the timely transmission and better patient management. Quality improvement, obviously this is a huge area. You can look at examples all across the country where we've determined what interventions are more effective. Data is also useful at the practitioner level for decision making. A doctor can look at the latest articles and information in a much more timely way than they might have just a decade ago. They can collaborate online to help determine their decision making. Certainly consumer empowerment. I think this is the one area where we have a lot more opportunity to go. There's a lot of data out there, but quite honestly, from a consumer point of view, a lot of it is not usable at this point. And I think this is where the conference today is very important, because we're bringing together data researchers with techies, and it's oftentimes the techies who can say, well, this is how you make the data useful to the consumer. And then finally, I think it helps with innovation and looking at new delivery models and what actually works. This is just one example of one of the things that I used to love about research when I was here at the Rockefeller Institute, is data can tell you things that you wouldn't otherwise know that make you ask questions that you can then research and find out the answers for. This is a map of New York City, and it shows cost variation for chronic obstructive pulmonary disease. And the range in terms of total costs is staggering, $7,000 in the Bronx to as much as $30,000 in Manhattan. If you look across the state, the gap is even bigger. The range is $4,700 to $42,000. So it makes you question, why would there be such a variation in costs? And then you begin to see, is it related to population health? Is it related to what the doctors are charging? What is causing that variation? Just some examples of data in health. The first one, hotspotters. I'm going to take another poll. How many people have read Atul Gawande's Hotspotters article? Okay, a couple of you. You may be familiar with his work. He often writes for The New Yorker, but he's a physician based in the Boston area. And I think he does a wonderful job of translating the data world, the health policy world, for policymakers. And he wrote an article, I think it was in 2011, in The New Yorker called Hotspotters. It was about a doctor in Camden, New Jersey, of all places, who was training to become a neuroscientist, I believe, at the time, or neurosurgeon, and came across a gunshot victim and looked at trying to help treat him. Unfortunately, the victim ultimately died. He was a student at Rutgers University. But it made him curious as to whether he was living in a high crime area, and he began to look at the data that the police department at the time had. And you all remember CompStat and how effective that was at helping policing in New York City. And he said, how come we don't have this for healthcare? So he dug and he dug, and it took him at least a good year of work and working with local providers. And he found that at one of the hospitals, they had 36 what they called super utilizers who in 1 month would make an average of 62 visits to the emergency department in 1 month. That average cost was about $1.2 million per individual. So if they could just focus on those 36 super utilizers, they could bring costs down, and they did, by 30%. So I think it was a perfect example of the power of data to inform policymaking and inform public health. Another example, Medicare is now using value-based purchasing. It's about looking at what you're paying for, and are you getting your value? Are you getting outcomes? They're paying more for results. Disease registries, which I'm sure Dr. Burkhead will touch on, that help with tracking and prevention. IBM, which most recently in 2011 developed what was known as Watson. How many people have heard of Watson? You might have seen him on Jeopardy. I actually went down in person and met Dr. Watson. He was able to answer my question. I went down to the location in the Hudson Valley where Dr. Watson lives, and can tell people answers to perplexing health questions. I think it's gotten to the point where it's able to better understand the natural language that we all speak, so it can actually process and think, so to speak. And it is actually going to be used by some hospitals in New York in the coming year to test it out and see how effective it is at helping to diagnose and make recommendations about what treatments are appropriate for individuals. And then a third example, since I had Dr. Watson, I had to have a ELISA on there. ELISA is a Boston-based company that does medication reminders for people. But it's an intelligent medication reminder, so it can tell which people need what kind of reminders, when they need them, and what types of reminders they're likely to respond to best. So I think it's just a range of examples that shows the power of data. In the midst of all this, we have health care reform going on, and I think that it's important to just remember the role of that in all of this, and what data and technology can do in healthcare and what healthcare reform is trying to achieve. Accountable care organizations were a big part of the Affordable Care Act, and you can't really determine if you're having accountable care if you don't know what your outcomes are and you don't know how much you're paying. Ultimately, with accountable care, you're rewarded for providing better care at less cost, and you need the data and technology to do that. So the organizations who have been accountable care organizations, been deemed so by Medicare, are those organizations who were pioneers in this area, who invested in the technology up front. They're also the same entities that have to understand how risk works in markets, if they're going to take on that risk and be able to manage that risk in terms of the patient population. I think with both patient-centered medical homes and the health homes, doctors are not able to effectively manage patients unless they have the data and information that they need to achieve that. We've had a good amount of success, I think, here in New York in both the patient-centered medical homes and the health homes. And then, of course, reimbursement being tied to results, which was another big part of the Affordable Care Act. One of the things that I think Dr. Shaw may touch on today is tying those things together. It sounds easy, reimbursement and results, but they actually come from two different data sources. And what we're looking to do in New York is to take those two different data sources, which is information about patients and the outcomes for those patients, and information about what we're paying for those services, and putting the two together. Which brings me to New York. These are just some examples of what New York has already done, and I think a lot of people in the room are probably familiar with these initiatives. Dr. Burkhead will talk about some of the uses of environmental public health tracking, which we've been doing for years. The state has also made a huge and significant investment, as has Governor Cuomo, in the State Health Information Network, New York, and the regional health information organizations to help with the data collection, to help with the processes for getting that data going forward. The New York eHealth Collaborative, NICE as it's called, is very important in all of this, because in order to use this data and to have it be interoperable, you need an entity to set those standards, to determine what can be collected and how it can be collected, and how it has to interact between different entities who have already invested significant amounts of money in creating data capabilities. The all-payer claims database, which is something you will hear more about, and you'll hear more about it from Dr. Shaw, who can probably explain it better than I can. But this is the piece right now that I think is missing from the conversation. It's claims data, so that you're looking at what services people are getting and how much it costs. That's one piece of it. You want to be able to tie that to the outcomes in the patient data. When you put those two together, then you can say, are we delivering the best care at the lowest price? So we're working to build that capacity in New York. We think it's critical for the next step in innovation and moving public health forward. And then all of that data can then be used for regional planning, community planning about improving population health and improving patient outcomes. We've got some great examples already here in New York. Medicaid program is using that data right now. The Rochester Finger Lakes Health Systems Agency, which is a collaborative group of businesses, providers, consumers, insurers out in the Rochester area, was recently designated one of the lowest Medicare spending places in the country, in part because they have had the capability now for several years to look at some of the claims data and help to manage the patient population out there. North Shore Long Island Jewish is also doing a number of things in this area that are innovative. The Community Healthcare Association in New York State also has invested significantly in IT and data. So we have a lot to be proud of in New York. Some examples of success, I already mentioned Rochester, cited for the lowest Medicare spending. The National Committee on Quality Insurance found that New York is a national leader in Medicaid health plans, second only to Massachusetts. I think that's because we've got a great shop within the Department of Health that does look at this data, looks at the quality assurance reporting requirements, and uses that to help better manage the health plans and what the quality outcomes should be. And then I mentioned North Shore. They were the 2013 iPro Quality Award winner for their work. So I mentioned the all-payer claims database. There are a number of states who are interested in doing what New York is doing, so this shows you where they are in terms of their progress in this area. A good part of Massachusetts, New England has existing all-payer claims databases, and then there's certain parts in the middle of the country where that's also true. We are in the phase of implementation. Nobody's told me how long implementation takes, but we certainly are investing in this area. A strong interest in many states, but you can tell that there are a lot of states who really have not made the investments yet to get them to the next level. So moving forward, there are a number of challenges. Cost, I should say, is one of them, which is the last one on there. These things are not necessarily inexpensive to build. Readiness, I would also put up there as one of the top challenges. It is a huge investment, but there are many different people involved, and unless those people use the technology, it's not necessarily going to be effective. So getting ready in terms of doctors' offices, having the technology readily available, hospitals having it, even the consumer and individual being able to use what's there. Usability, and I will touch on usability as both a challenge and an opportunity. Data fragmentation. That's why I think the emergence of the all-payer claims database is important, why I think the New York eHealth Collaborative is important, because it's helping with the data fragmentation, bringing together those 5 different sources that I talked about on the first slide so that they can be integrated and more effective. Certainly we need some flexibility and be able to scale the infrastructure up from what it is right now. A lot of providers have invested a tremendous amount of money in technology over the years. Not all of the data is compatible at this point, and this is out of my wheelhouse, so I don't really know what I'm talking about when it comes to the compatibility of data, but I just know that sometimes things don't always work together. So I know that that's an area of investment. Ownership of the data is another question, and there needs to be a conversation about who ultimately owns this data. It can be tremendously useful if you look across a large number of people to be able to say, look at these patterns. Is that the government's data? Is that the consumer's data? Is that the provider's data? It's still something that's an open question. Security, I think we probably made some huge strides with HIPAA, making sure that there is security, there is privacy around the use of the data. And again, I mentioned costs, but it really does require a significant investment, and being able to demonstrate that return on investment will be important for the state if we're going to get the support to move it forward. So in terms of opportunities and priorities, I think Governor Cuomo has been very committed to open data, thanks to the leadership of Dr. Shaw. And the health department was really one of the pioneer agencies out there putting data on the website, making it available to the public, looking at the potential and opportunities that there are from putting data out there for researchers. I think another opportunity is being able to use and analyze the data at all different levels. So it's not just the physician who's using your data for an electronic health record, but it's also the hospital that the physician works for, so that they can look at continuous quality improvement. And it's also the consumer, so you can make more informed choices about where you want to go to get better health care. Ultimately, using the data will help drive more accountability. It will help drive transformation in the system to a system that is certainly more effective, higher quality, lower cost. So the question I think that we're here today to help answer is about how do we use it? Because there's a lot of data out there. It's right now very disparate. How do we bring the different fields together of information technology, of research, of practitioners, of policymaking? I would call that process, once we get there, data democratization, where we're all part of the same community. And that's why I think this conference is very important today. So I appreciate the opportunity to be part of it. Thank you.